Hi everyone, and thank you for having me. Today we'll be talking about rehabilitation and vestibular disorders. Today we'll start off with introduction into rehab, getting people to understand what the team rehab does, and then looking at vestibular issues from the rehab perspective and what is important and how do we use these issues to come out with an exercise program. And then looking at the role of rehab in vestibular disorders. Okay, there are a few concepts that probably will help if I introduce it to you to understand where we're coming from. Okay, so giving an idea what rehabilitation is all about. WHO defines us as to having a set of interventions. Okay, the entire team brings a patient from what level of function they are at into something they can do better than what they began with. Okay, we try to get them to do better. For example, if you have a patient, and this example I will use repeatedly, if you have a patient who's had a stroke, who's had dense left hemiparesis, and for him to move on the bed, it becomes a challenge. So with the team approach, we'll try and figure out how to get him to move on the bed, to sit, and then later to stand, to walk, and then to go back to activities of daily living. So, like I said, it is a process of active change. The patient has to actually take part in his own care, right? He doesn't stay back, it's not passive. So it enables somebody who's of different function to reach to a level of functional improvement through a series of repetitive educational training, which requires the patient to be active. For example, this patient with the left hemiparesis, from the bed, he has to learn how to move on the bed first, okay, because of the truncal weakness. Once he's able to turn on the bed right and to the left, initially the physios will be hands-on, will move him with a lot of effort. And later, once he figures things out, the physiotherapist can reduce the effort and he can maximize the effort. So then he has learned, that's the education bit. And then he has learned how to problem solve with the help of the physiotherapist on how to turn on the bed independently. Then he can move to the next goal, which would be maybe sitting up on the bed with or without support. Okay, now we look at this slide. It talks about outcome measures. Outcome measures are measures that we use in rehab to be able to quantify how well a patient has done. So, for instance, if we use MMSE to assess the patient mini mental state examination for a patient with dementia to see how bad or how good the cognitive function of the patient is. If I say the MMSE is 23 out of 30, my team will understand what I mean, and somebody in Singapore will understand what I mean as well, because the MMSE is validated and it is reliable, and it is a gold standard. It is a tool that can be used internationally, so it's a good tool. So with this in mind, I know his cognitive function requires some help because it's a moderate weakness in cognitive function. So he will need some kind of cognitive rehab to address the issue that MMSE has brought up. So the intervention is cognitive rehab. We do a goal setting to ensure that he achieves that the goal that he wants for, to improve, let's say, in his memory. Okay, so we use SMART goals, which is specific, measurable, attainable, realistic, and in a time frame. Okay, so all of these goals will help in achieving his goal of improving his memory, and then after the intervention we reassess his outcome measure, and that MMSE would improve to maybe 30 upon 30. The entire process requires a team approach, and the team would have to discuss and have an open communication so that we know what's happening. Okay, so the entire team works at improving physical function. Okay, so we try to improve or restore function. If we can't, then we go towards compensation of function. Okay, now for example, when a patient has let's say amputation of the lower limb, it's a bit difficult to replace the limb with another limb, but we can do a prosthetic restoration so that he can improve his function to stand and to walk with training. Sometimes if the patient has right hemiparesis, and if he is right hand dominant, then we would have to teach him how to compensate with the left while preparing him and restoring the right side. So it's always a team approach. You'll have the patient and the family in the middle. Then you'll have other professionals like the occupational therapists who will look into activities of daily living and return to life roles. You have the physical therapists who will look in a vestibular dysfunction, will look into maybe some amount of gaze exercises as well, posture and stability. The audiologist is important in looking at vestibular functions, defining it and assessing it. Then the rehab nurse will help out with education. And also the psychologist is also very important when it comes to managing anxiety. The other physicians that we work with would be either ENT or neurologists. The rehab physician's role will be looking at the diagnosis per se, whether the patient is stable enough to participate in physiotherapy. Sometimes a patient with BPPV comes with hypertension, which is not very controlled, or has got chest pain, which adds to the dizziness. Those are the things that we look into before putting them through the program. And we would try to prevent further complications, like say if somebody's got high blood pressure and goes into physiotherapy, the complications could be an ACS or further things. Okay, so and we would advocate for the patient to get the best outcome, and we will try and help to coordinate the team. So in a nutshell, rehabilitation has the overarching goal to optimize a patient's functioning and reduce his disability. It's always a team approach. It is goal-orientated. It is individualized, and it has to be tailored to their particular goal. In this slide, you'll notice that we will take the patient history. The entire team will take patient's history based on their assessment. In this history, we'll ask about dizziness, about gaze instability, or any falls, or any hearing problems, vertigo symptoms, change of position. Then we will also do our physical assessments, which include central nervous examination, cranial nerves, ability to carry out cerebellar functions, to assess that as well. And we also check on their function. In their function, we will see whether the patient is able to turn, able to sit, able to walk, and also as he walks, what are the sways, what are the gait disturbances. Of course, the cerebellar examination would include nystagmus and also specific balance tests like the Sharpen-Romberg's, and things like that. Then vestibular assessments will be done individually, which we'll talk about a bit later. We get collateral history from the family. Another important thing about history is function. What part of the function is disturbed of the patient's activities of daily living? What is disturbed when the patient has vertigo symptoms? Okay, we've already learned about how to look at the ear problems and what are the problems in vertigo when it comes to the ear. What are problems and or how to do VOR. We will learn how to look at central problems. We look at vision problems as well as again visual adaptation. Now we're going to look at positioning, somatosensory, control of motor skills and control of posture, then how to bring it all together. Okay, so you already know dizziness, visual or gaze disturbances are the main problems, and then there's gait and balance disturbances. Okay, dizziness alone leads to about 7 million doctor visits in the US per year. Okay, it leads to significant activity and participation restriction. Basically, sometimes a patient with BPPV cannot go to work, cannot get up and do his own care, cannot manage the house. He cannot drive a car, right? So the causes are usually of a central cause, a peripheral, and I've also noticed they usually come in both as well. They have both pathology. The patient also comes with anxiety because of falls. That he also may have some MSK issues like musculoskeletal pain because he doesn't want to turn the head too fast, so he keeps it in a particular position. So he'll develop some neck tightness, and you can find certain areas which you can do some amount of massage or trigger point management. Then the patient comes with central cause of vertigo. They may come with stroke, so they have different abilities which needs to be addressed as well. Sometimes patient gets headache, vestibular migraine, and with all of this they have functional decline. Over here you can see that there is an input from the sensory and can eventually reach out to an motor output which manages the balance. Both of these are integrated. They're integrated in the cerebellum, and it includes the cerebral cortex and brainstem to carry out everything. Okay, so you know the sensory is always vestibular, vision or proprioception. Remember that the cerebellum is the main coordinating center together with the brainstem. And when the cerebellar cortex comes in, is as a child learns how to walk and has his falls, he remembers what kind of ground is safe to walk upright, what kind of ground requires different muscle activation that goes into his memory. So when he falls, when a patient falls, that adds to anxiety. Okay. So the motor output would know when you see a certain motion, you know what kind of reflex is required for your vestibular ocular reflex to capture, what kind of motor impulses are required to control your eye movements, and what kind of postural adjustment is required for different kinds of surfaces to walk on. This all is integrated to carry out a perfect balance. Okay, so you need to understand that there's peripheral and central causes of vertigo. We already know that. So when the patient comes into the office, we can see whether, and we can get the story, whether it's sudden or whether it's gradual. Both can have sudden. Central, of course, you would have that hemiparesis first from a stroke, and then later you will complain about dizziness. So that would be appears as gradual, okay? And if it is a peripheral cause, it is usually decreasing over time. Okay, and it can be an intermittent episode, and it's rarely continuous. Okay, whereas in stroke or in central causes, it's usually continuous. Okay, and the nystagmus would differ. In peripheral, you have torsional, upbeat. Okay, sometimes it's horizontal, and I find that in central, you find it vertical and it's spontaneous. Okay. And it does change direction, yeah, especially on the lateral gaze, depending on the coordination in the pontine lesions or whatever. And then the effect of head will be there, head positions will be there for PPVV, not so much in central. And you would have, of course, neurological issues with the central components. And rarely you would have any auditory problems, but you can get sensory neural deficits with central problems. And usually with Meniere's disease, you can have tinnitus, which over years leads to auditory problems. Okay. Now, what are the prognosis that we can see? So in acute peripheral causes, sometimes the patient will not be able to walk, will be able to improve in walking about 48 hours. Initially, they're just bedbound, they can't get up. After 48 hours, you can see them trying to get up and trying to stand with support, and then they go back to normal activities in 2 weeks and even almost back to normal for 3 months. But if you look at them, you'll find they have these minor problems, mild nystagmus still left, and they wouldn't go into a lot of balance. They would be very careful the way they walk. They wouldn't turn suddenly. They would just walk like straight, like a robot. Okay, so but you expect them to return to normal function within 6 weeks. Okay? Now, with somebody who's got an acoustic neuroma, after resection, you want to assess him before and after. And if you find that he has all these Romberg stares even at day 3, then you know he will benefit from some vestibular rehab. Okay. Now, in general, if a patient, especially central cause, has gone through the vestibular program and overdoes himself, on good days he thinks, oh, I'm good, and then he just goes on working, working and forgetting to rest or forgetting to do his exercises, he can actually have a sort of like a relapse or becomes worse after a day or two. And sometimes if we don't do our exercises, we become inactive. That also adds to probably a bit of a relapse. Okay. But it's not necessarily a dysfunction. It's probably just it's what we call as a deconditioning. So in recovery, the overall mechanisms include vestibular adaptation and substitution. Adaptation requires adjusting of the gain of the vestibular ocular reflex and vestibular spinal reflex. How do we make it better? By sort of like neuroplasticity. Substitution, you would want to come in when you have lost the vestibular function. What else you can use to make it better? Well compensated indicates that the recovery is good. Poorly compensated is partial recovery. Okay, so let's try and understand balance. Balance is the ability of somebody to maintain the center of mass. The body's center of mass is around the sacral region when the patient is upright. The base of support is how much of support the legs are supporting the body. Okay, the wider the feet are apart, the wider the base of support. If you add a walking aid around it, you increase the base of support. Okay, now how does a proper functioning balance system work? If you are walking and you see something moving down the road, you know that it moves either faster or slower than you. Your VOR will pick it up. Okay, you know in which direction, you know what is the orientation in respect to gravity. All of this helps you maintain in relation to that object moving your own balance. So balance is maintained by a complex set of sensory motor control systems. You already saw it in the previous slides, okay, in the previous lectures. So the sensory input will always be vestibular, vision, and proprioception. Okay, vestibular will mean motion, equilibrium, and spatial orientation. All of it, sensory input, is all of the senses going in, goes through your brainstem, your cerebellum, your cortex, and comes out back to your eye through the VOR and body muscles, which is your ankle and hip strategies, and trying to get a proper balance. Okay, so remember outcome measures. So what are the outcome measures for balance? One of it is work balance. This is what we call as a static balance test. That means the patient you assess the patient while he's sitting without support, which means he doesn't lean up, he sits on himself, doesn't lean back, sorry. Then when he's standing with his eyes open or closed, and when he's standing, he doesn't need any support by holding the wall and things like that. Stands with the feet together, one foot up, and turns and things like that. Then he goes into dynamic balance, which he shifts from sitting to standing quickly or standing to sitting quickly. And then he moves from the bed to the wheelchair and turns and stepping up on a stool and things like that. This is a 14 levels item scale, and it's a 0 to 4, where the worst score is 0 and the best score is 4. It's a 56 upon 56 is the best score. 41 to 56 indicates a low risk of fall. Dynamic gait index looks at dynamic balance. Okay, you look at walking on a certain level, how fast they turn with their head turning, okay, with horizontal turn and as well as vertical head turns, walking over an obstacle or walking around and doing stairs. Okay, so this is all dynamic balance. So it scores 24 at best. Again, it's a 0 to 3, 3 being the highest score and 0 being the lowest score. Okay, so motion sensitivity test is another type of outcome measure that assess your motion. Okay, so you will look at the test. You can see that it checks on sitting to supine, and then it also sees from supine to left side, and then turn to the right, and then from supine to sitting, and then you got decal pikes, then going to the left and then to the right, and then putting your head sitting, and then put your head to the tip to the left knee, and then head up from the left knee, and then down again and up again, and then walking and turning right and left. Okay, so now if you notice, there's how bad or how easy it was from 0 to 5, 5 being severe and 0 being no problem, and how long it took for the patient. Okay, you get a score which you will calculate based on this formula, and your coefficient or MSQ quotient, you can see if it's 11 to 30, it's already moderate. Okay, you want to focus on where the patient is unable to do, and this will help you in your postural training later on, which is unable to do, and you need to retrain that area. Right, now there's something else which we use, is called computerized dynamic posturography. Now this is it's a huge machine. Not all centers have it, but if you have it, it's very good to have. If you don't, then you just use the basic outcome measures that we've used just now and work around it. Okay, so but to introduce this concept, it is a very objective way of figuring out what's the problem with the sensory component, what's the problem with the motor component, and how to use the central adaptive, where is the problem with the central adaptive functional impairments of balance. It is complementary to the vestibular nystagmogram or the MRI. Its focus is to work together and figure out what's best. Okay, so it's a very interesting concept. There are several protocols that are used in the computerized posturography. The first is the sensory organization protocol that looks into vestibular, vision, and proprioceptive symptoms on the balance control. Then there's the motor one, looking at how the bottom force plate, the plate where the patient stands on in the system, and when it moves forward, what happens to the patient's body? When it moves backward, what happens? What are the reflexes, and how does the reflexes respond? The adaptation one looks at, again, when the surface becomes irregular or unstable, what happens to the toes? Does it go up or does it go down? And how much does the body move? Does it move too much? Does it move too less? Okay, all of this is summarized, and there's an algorithm that generates the results. Okay, so if you look at here, this is the sensory organization test. Okay, this is what I was talking to you about. You have a swaying part. So you have the vision, the first, and you got 6 stages. You have the patient standing on a machine which has got a plate. He's being harnessed up. I'll show you a video. And this thing can be moved. And the next stage, everything is static, but his eyes are closed. The next stage, His eyes are open, but this moves, and his legs are static. Support is fixed. Then the next is only the support is moved. His vision is open. He can still see. He's not closing his eye. Next, his support is moved and he closes his eyes. The third, he opens his eyes and this wall moves as well as the platform moves. So it gets harder. Now we want to see what the result is. With that result, we can determine what are the exercises the patient needs. The physiotherapist can determine what the exercise the patient needs. Okay? So I'm going to give you an example.
Position patient.
Yeah.
Harness on.
Yeah. You can see the patient is positioned. He's got a harness on. And I will start the program. You get to choose which one you want to start with. Usually we start with the sensory organization. You can see the platform that he's standing on. And we will start the test. This is done by my physiotherapist for a previous vestibular course. Okay. So you can see we want to see the patient in the center. And all of this will be the 6 steps that we'll be looking into, which we talked about just now. The patient will have the same screen in front of him, in front of this wall, and he is instructed to stand in the center and maintain that center as much as he can. Okay? So you can see he's on a harness. This is the movable plate and this is the movable wall. And he's got a computer in front of him over here. So now he's centered. Okay? So he's just centered. The first step is to stand without this moving or without this moving, but his eyes are open just to get an idea of how he's functioning. The second Then we move on to the second. We're doing the third step now. In this, we'll try to get him center again. Okay. And then we're going to move this now. His eyes are open. You can see this moving. Yeah.
Ni kau buat-buat ke memang betul ni? Ni kau buat-buat ke memang kau betul goyang? Ni buat-buat.
So you can see that there's movement here, as well that he's now become red. Okay? Okay. So now, we're going to move this. All of this will move again. This part will start moving too, and his eyes are open. Okay? So we're going to move for this last one, which is the hardest. Again, he's centered at the moment. Can you see his thing moving now, as well as this? So that shows us his strategies of his hip and his ankle is not good. This plate is already moving now. You see that his entire trunk is going either backward or forward. And you see how much the body has moved? Okay. Alright, so this is what a normal algorithm would produce. It would produce a chart like this. Okay. In this chart, you would see that there will be level 1, 2, 3, 4, 5, and 6. Okay. So, and then you do a sensory analysis, whether it's the somotosensory, vision, vestibular, and then it's a compensate of all. And how, you saw him moving around. So this will decide his center of gravity alignment. And then we will see what strategy we need to work. This is the ankle strategy and this is the hip strategy. Talk about that in a moment. So this is a case of a 35-year-old lady who complained of dizziness of 1 month. Her physical examination, everything was normal. Even her BNG, medications did not help. Even a decal pike, so all normal. Rhombus were all normal. But she complains of just dizziness, no true vertigo. So when we did the CDP or the computerized posturography, so this is a patient that is just taken from the books, yeah, and patient is either not receiving. You can see that she's got a lot of vestibular components. Okay, this main vestibular shows up, and you can see she's all over the place when she's moved, right? So the patient is either not receiving the information from the vestibular system, or she's not using it. and she's using more of her ankle movements are not helping in her recovery. She's out of the normative picture. So the physios worked with her on improving her ankle and hip movement. Okay, they increased her difficulty. They worked on her balance and adaptation, a different adaptive ability. And they came after the PT sessions. She also had home exercise program, and a repeated CDP showed that her levels are now all back to normal. She's found good equilibrium. She's already in the center of gravity. She's maintained alignment, and she's used the strategies of the hip and the ankle well. And she does not have a vestibular component anymore, and she does not have any more dizziness. So sometimes, even though patients are well compensated, like I said, they have restricted themselves and they have not moved to a place where they can be free of their symptoms. Yeah, so they have compensated probably with their vision or with other strategies rather than using the vestibular to the best that they can. So with the strategies that the physio have put in, they have strengthened her balance and also used their vestibular strategies in restoration. So this would be adaptation techniques that they have used. Let's learn about that further. So vestibular rehab can facilitate vestibular recovery through vestibular mechanisms, through vestibular adaptation, using substitution of other eye movement systems, substitution by using vision or somatosensory cues or other postural strategies, and habituation. Some of the principles would be compensatory, or in a way, it's actually neuroplasticity. As you train and train for this patient, they will start adapting to something new. So what was weak will become stronger. So if you repeatedly train and provoke the head and eye to try and reduce the error and improve the VOR, then the patient will adapt to this new pathway. Okay, if at all of this fails, like he doesn't have a strong vestibular component, then you will have to substitute with other sensory inputs like the vision and the somatosensory. We also look into postural control exercises such like improving the trunk, when the patient sits and stands, improving dynamic balance. This will improve falls prevention. If the patient has anxiety, look into relaxation training. Don't forget the specific maneuvers. Remember, it's all about goals. So the goals for vestibular rehab is to improve gaze stability. That means you're attending to the nystagmus. Then you want to improve the patient's balance so he doesn't fall. Improve the vertigo so that he become more and more active. Because he's more active, you can improve his function. So the indications for vestibular rehab would be patients that are stable, who can participate in a program. They may have a purely compensated vestibulation. They may be of any age, however long and however intense it may be. As long as the patient can carry out some exercises, even if they do it a few times a day, it will help them improve. The peripheral causes that usually is dealt with is usually BPVV, vestibulopathy, or Meniere's disease. Central causes are usually stroke, TBI related, traumatic brain injury related, or tumors. So focusing on improving gaze stability. Remember, nystagmus. So how do we improve it? We want to decrease the vestibular response to any head movement. So if you turn the head, there's just too much nystagmus going on. How do we do it? Focus on one stationary object. We start with just sitting and looking at that object. The object we can place at one arm's length or the end of the room. Okay. There are a few ways of improving it. So once the patient is just focusing, sitting, he looks at one object, which is just turns his head, as in the picture here. He moves, the object is stationary, moves to the right and moves to the left. Later we make it the amplitude more, change the amplitudes faster or slower. Okay. Then we increase the head movements, faster, slower, to the right, to the left, up and down. Okay, you can do that 4 to 5 times a day, and you increase it to 20 to 40 minutes per day. Add to your balance and gait exercises. He would do well in his vestibular rehab. Okay, on further enhancing eye movements, we look at Saken and VOR. The two pictures here in A and B. In A, the eyes are open. He looks at one object, and then he looks at the next object. Then, focusing on the next object, he turns his head. In B, he looks at one object, he closes his eyes, turns his head, but the eyes are still focusing on that object, and then opens his eyes. Okay, so he repeatedly does this. Although it's difficult first, he repeatedly does this and it becomes easier for him. Okay, if the patient cannot move his head so much, we use optokinetic devices, just like lights or just a simple card which has got stripes, things like that that can help the patient work on a target, a visual target. For postural stability, the goals are to use a very stable visual reference. When you're walking, focus on a visual reference, which is not moving. And then interpret what you're walking on, the surface that you're walking on. Use the vestibular feedback, understanding the motion, understanding the spatial recognition of the environment. Then engage your postural and the movement strategies to ensure that you get good strategies in place. If the patient has a higher dependency for vision, then we want to train him. That means his vision problem is not strong. So we want to retrain and redo the neuroplasticity. So we get him to focus on something that's moving. Either it's outside, looking at cars that are moving, or in the house looking at TV scenes that have or movies that have high-speed car chases, or even looking at curtains or some with stripes, okay, or any exercises that require balance and visual input together. But your surface has to be stable. If somatosensory based on assessment is the problem, then you want to train the trunk first. Make sure the trunk is strong, truncal exercises. Do a lot of dynamic standing and sitting and balance that way. And then change the surface. So the patient is trained for different dynamic balances on a carpet or a compliant foam, okay? And then he can, just like catching a ball on a carpet. Sometimes both the visual and somatosensory cues are altered. You just can't do anything about it. Then you have to really improve the remaining vestibular function. You have to come up with a plan to improve it with the goal of still maintaining postural stability. How to do this? Target also the vision and the somatosensory. Try to get as much as you can. Initially with eyes open, eyes closed. Then change the surfaces. Then start walking in different environments. Crowded malls, at night, change the lighting, so at night. Then start doing exercises, walking down a straight path. Therapists will call out, turn to the right, turn to the left, or walk down a spiral staircase. When you're about to fall, there are a few postural strategies that come into place. This is for a normal person. There's the ankle strategy, the hip, and the step strategies. So these are the strategies that we have learned as we grow and have had the plasticity growing up, so that it prevents the body from moving forward too much or moving backward too much and keeps us stable. The ankle strategy is very dependent on the somatosensory, which is the surface. The hip strategy is very important, very dependent on the vestibular function. Okay. To work on the ankle strategy, we start by teaching the patient how to sway back and forth, and then side to side, small ranges, then increase the ranges. Remember, when we sway them, we want to keep the hip and the knee extended and not flexed. Once they achieve this, then you want to give slight perturbations. Make sure that you have all your safety precautions on so the patient doesn't fall. Slight perturbations at the hips and the shoulders. Then, once the patient's good at all this, then we start teaching them how to reach and lift and throw. Hip strategies, we need to working on a narrow beam, standing on a heel and toe, or even standing on one leg, stepping up, stepping down. Remember, we did one outcome measure called motion sensitivity test. And remember, we recorded how long it takes to complete that particular section of the test, like doing the Dick Hall pikes on the right and then getting up on the right, or putting your head to the right knee and then getting up again. And if that particular part of the test is difficult, then you want to retrain until the patient is able to do that. Okay, so that is part of improving. It's an example of how you want to improve that vertigo. Once we've already targeted VOR, we've targeted substitution, we've targeted postural control. Once we've targeted everything, then we want to bring all the exercises together and help the patient improve in their activities of daily living and walking, return to normal life roles, return to sports, and then target the other things that come along with the patient, like the migraines, even the neck rotations, address the trigger points issues. With all of this, then you'll probably have questions as, who's ready for rehab? When do they start? How long will the program be? How do I stratify? What kind of outcome measures to use? Does anybody have any experience? Thank you so much for having me. With my next talk, I hope to answer these questions. Have a good day.